Indra, can you open? Oke. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, good afternoon to all distinguished guests, respected speakers, and participants joining us from all across the globe. It is a great pleasure and honor that I welcome you to the second International Patient-Centered Care webinar, organized by the Patient-Centered Care Institute, or PCCI, under CARS, or ICAHO, in collaboration with ASQA, the Asian Society for Quality in Healthcare. This webinar brings together leaders and experts in healthcare quality to share global experience, innovation, and strategic insight on patient-centered care, a model of care that prioritizes dignity, compassion, and true partnership between healthcare providers and the patient. Today, we are truly privileged to hear from Dr. Carsten Engel, CEO of ISQA from Denmark, who will share the latest development from the newest white paper of ISQA. The second is Salma Juni, from board member, global health expert from Jordan, who will present her experience of patient-centered care in Jordan. And the last one is our distinguished professor, Dr. Tonang Dwi Arianto, a national figure in Indonesian healthcare transformation, who will highlight the PCC implementation in Indonesia. We believe this insight will greatly inspire our collective journey in promoting patient-centeredness, especially in an era where healthcare must become more equitable, transparent, and responsible to patients' voices. Let me also take this opportunity to encourage all hospitals in the region to join the Hospital Patient-Centered Care, or HPCC Award, as we continue to recognize and celebrate hospitals that embody excellence in delivering PCC. On behalf of the organization committee, I thank all participants for joining this free international webinar. Your presence shows your commitment to advancing healthcare quality for all. Let us use this moment to learn, reflect, and connect across borders, because better healthcare begins with listening to the patient. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Let me start with showing our schedule. This is our schedule. Opening has been done. After this is the prayer by Dr. Juni Dharmajaya. And then a welcome speech from the Chief Executive of CARS, Dr. Sutoto, MKes Fisqua, Ahmed, CRP, MQM, CHAE. Welcome speech of the Chair of the PCCI, Dr. Hani Rono Sulistyo, is me. After that, the first speaker will be Dr. Carsten Engel, followed by question and answer. The second one will be Salma Yauni from Jordan with question and answer. And the last one will Professor Tonang with question and answer. Closing by the chairman of PCCI, Dr. Nico Alumenta Nefro, and closing. Dear, now I give the chair to Dr. Juni to do the prayings. Thank you.
Mike, Dr. Juni. Belum terbuka. Ya.
Okay, I'm sorry, participant. Dear respected colleague, friends, and participants, before we begin, please allow me to offer this opening prayer in the Islamic traditions. We fully respect the diversity of faith among us, and we invite everyone to join in this moment of reflection, each in their own way and according to their own beliefs. Let us pray. Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. O Allah, the source of all knowledge and wisdom, we thank you for this opportunity to gather virtually from across the globe. We ask for your guidance and blessing as we begin this important webinar organized in the spirit of collaboration between the Patient Center Care Institutes, the Hospital Accreditation Commission of Indonesia, the Asian Society for Quality in Healthcare, and with the valued support of experts from the International Society for Quality in Healthcare. Grant us clarity of mind, sincerity of heart, and strength of purpose. Bless all speakers, facilitators, and participants with meaningful insight and fruitful discussions. Help us to learn from one another, to share knowledge that brings healing, dignity, and compassion to patients everywhere. May this event contribute to the advancement of safe, quality, and patient-centered healthcare, not only in our respective countries, but around the world. Forgive us our shortcoming and accept our humble efforts. May peace, mercy, and blessing be upon us all. Amen. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Juni. Please, Dr. Sutoto, it's your time.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Greetings of peace to all. Good evening and welcome. It is with great pride and gratitude that I, on behalf of CARS, the Hospital Accreditation Commission, warmly welcome all to the second International Patient Center Care webinar, a collaborative initiative between CARS, the Patient Center Care Institute, and the Asian Society for Quality in Healthcare. This event marks a significant milestone in promoting a global expansion to patient-centered care, a vision where quality healthcare is rooted in empathy, respect, and shared decision-making. In Indonesia, the implementation of patient-centered care has been gradually integrated into hospital accreditation standard and national health policies through structured communication, shared decision-making, and respect for patient values and cultural background. Healthcare providers are now striving to transform hospital into more compassionate, inclusive, and responsive institution. CARS continues to advocate for PCC as a pillar of quality and safety in healthcare delivery across the nation. We extend our heartfelt thanks and highest appreciation to our distinguished speaker, Dr. Carsten Engel, CEO of ESQA, for his invaluable insight to ESQA latest paper, a global reference of implementing PCC. And Ms. Salma Juni, CEO of HCAC Jordan, for sharing Jordan inspiring journey toward a truly patient-centered healthcare system. And Professor Dr. Tonang, for his compelling reflection on how PCC is evolving within Indonesia's hospital and local healthcare culture. And today we are honored to have Dr. Kadar Marikar from MSQ at Malaysia with us today. Thank Dr. Kadar. Ladies and gentlemen, as the universal motto goes, nothing about me without me. This reminds us that healthcare quality is not just about clinical excellence, but about engaging the patient as the true partner in their care of journey. Let us make this session a meaningful exchange of knowledge, commitment, and global solidarity in the mission to deliver compassionate, equitable, and patient-centered healthcare. Thank you and enjoy the webinar. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much,
Waalaikumsalam warahmatullahi wabarakatuh.
Dr. Sutoto. Now I will give a speech as the chairman of Patient-Centered Care Institute in Indonesia with Dr. Nico. CARS, Patient-Centered Care Institute, are working very hard to promote PCC in Indonesia. We make this as an effort to make our movement, and we also make a great steps onto PCC in Indonesia by performing a hospital patient-centered care award to hospitals that comply our standards, national and international. By this, we hope that we can continue to promote the Indonesian hospital to the best grade in the world, hopefully. Thank you. Now we are moving to the first speaker. Please put Dr. Carsten Engel curriculum vitae. Dr. Carsten, I'm sorry that your CV is Indonesian language. So we will change that later. Okay, please have your time.
Yes, and I will share my screen now to share my presentation with you.
Yes.
So I hope you can see it now.
Yeah, it's starting.
Good.
Yeah, okay.
So good evening to all of you, and thank you for the opportunity to speak to you tonight. It's both an honor and a pleasure for me to talk about a topic that is close to my heart. What I'm going to talk to you about is the newest white paper released by ISQA. It's, as you can see, a white paper on on patient safety, but this is actually, as will emerge from when I'm talking to you, also very much related to person-centered care. So We recently, on the 3rd of April 2025, at the WHO 7th Global Ministerial Patient Safety Summit in Manila, released a white paper, Safe Care is the Right Care. And the white paper is freely available to everyone on ISQA's website. Our intention with this white paper was to create a guide to planning and managing the implementation of patient safety at the facility level. We deliberately decided to focus on the facility level, the meso level. The facility level, the facility leaders and the facility management, they have the challenging task of connecting the macro level where national policies, priorities, regulatory activities, etc. are decided with the micro level, the level of the clinical team where actual care is produced, or as I would prefer to see it, co-produced by professionals, patients, and caregivers.
Excuse
I
me,
will
Carsten, your slide is not moving.
No, it will be moving in a moment.
Okay, sorry.
So I'll present the white paper to you, and I will then present in some more details the implementation strategies related to patient, family, and carer engagement and empowerment, which is the focus of today's webinar. And this is just to show you that the white paper has been authored by a work group established by the Patient Safety Task Force that we in ISQA set up in 2024 at the suggestion of the WHO Patient Safety Flagship to work with partners and ISQA members to promote patient safety. As you can see, a very diverse group of authors. You might ask why we need a white paper now. Patient safety has been on the agenda for more than 25 years, and an enormous amount of books and papers have been written. But nevertheless, as you know, and as I will show you in a moment, patient safety is still an issue. We aimed to produce a brief and yet comprehensive guide for leaders at the facility level, and we wanted to show you how you can structure your work to move towards a safer system. Safety is not just making thousands of individual processes safe. A complex system can't be managed top-down like a traditional assembly line. Instead, it's also about creating conditions and tools for each team, including the patients they are caring for, to work in a safe way where they are and to develop their capacity to anticipate, monitor, adapt, adjust, and learn as they work. That patient safety is still not an achieved goal is demonstrated in this recent report from the WHO, the Global Patient Safety Report 2024. Here we can read that 12% of patients experience harm across medical care settings. As much as 12% of adverse events cause permanent disability or patient death. Unsafe care causes more than 3 million deaths each year, and around 2/3 of all harm occurs in low and middle income countries. It's also well documented that we still face what is aptly called the 60-30-10 challenge. We know a lot, but we do not use what we know well enough. It has become increasingly apparent that our current health systems are not built to last. While 60% of care is delivered within guidelines based on evidence or expert consensus, 30% is of low value or wasteful, and even 10% is resulting in direct harm to the patients. 40% of what we are doing does not provide much value to patients. It even generates harm that must be taken care of. And imagine what we can do if we mobilize perhaps 50% of the resources that are spent on nothing or harm to really create value. One of the first studies of the incidence of preventable harm was performed by a group at Harvard in Boston and published in 1991, more than 30 years ago. The world was stunned to learn that adverse events occurred in 3.7% of hospitalizations, and that a little more than 1 in 4 were deemed to be preventable. Surely we can do it better now? Well, a similar study was published in 2023, also from Massachusetts, and found an even higher rate of preventable events, as you can see from this slide, and still roughly a fourth were deemed to be preventable. And the authors concluded the paper with these words: "Our findings are an urgent reminder to all healthcare professionals of the need for continuing improvement in the safety of the care we deliver." Now, you might consider that it's too expensive to provide safe care. We can't afford it. Well, the data on this slide shows that we can't afford not to. You can see the difference between the two curves. The one shows the upper, the lower one shows the actual global world product, and the upper one shows what would it have been without the costs we incurred to mitigate and the losses incurred from healthcare harm. And it's a really impressive difference. While the costs from year to year may seem moderate, when they are accumulated over time, the loss is very considerable. So we can't use finances as an excuse. Is a problem then that we don't know what to do? No, this is also not the case. The WHO published a comprehensive action plan in 2021, which outlines a comprehensive set of actions for all levels in the healthcare system, for governments, healthcare facilities and services, stakeholders, and the WHO Secretariat. And this provides you with a high-level roadmap. And this roadmap is structured as a set of actions presented in a matrix of 7 strategic objectives, 5 strategic objectives that would help to achieve each of these objectives. So there are 35 strategies, and for each of them, actions are identified and presented for the 4 levels I mentioned before, the 4 levels of persons involved in persons, organizations involved in care. So we have a quite comprehensive and detailed roadmap. And this was published a number of years ago. And how are we progressing? Well, the WHO report from 2024 examined that. You will notice that the outer limit of this radar diagram is unfortunately not 100%, but 70%. So there's still a way to go. Strategic objective number 3, safety of clinical processes, is actually performing best, but still far from perfect. And the report gives data for all 35 strategies and data summarized across each of the WHO regions. As expected, there are regional differences, but no regions has met all the targets, and even in wealthy regions, there are strategies where the score is only on a basic level, less than 4 out of 10. So there is a lot to do. Now, what does ISCO propose then? We propose that you structure your strategic thinking and planning around 4 foundational pillars. The first one is advocacy and leadership. Strong leadership is essential to embed patient safety as a core organizational value, and advocacy at all levels will foster accountability and ensure commitment to patient safety priorities. Health worker education and safety is highly important. Empowering health workers with knowledge and skills and tools is critical for delivering safe and high-quality healthcare. Prioritizing staff well-being enhances patient outcomes. Some argue that staff well-being should be our highest priority, that it drives everything else. Not that it's the sole driver, but it's a very necessary condition. And then the third pillar is patient, family and carer engagement. Empowering and engaging patients, families, and carers fosters trust and ensures shared decision-making, and including patients' perspectives with active collaboration between patients and healthcare providers prevents harm. And the fourth pillar is improvement in clinical processes. Adopting evidence-based practices with data-driven clinical workflows reduces variability and standardizes care, and measuring progress will enable continuous quality improvement for better outcomes. This table may be hard for you to read and grasp quickly, and that's not my intention that you should, but what it says is that within each of the 4 pillars, we identify a key driver for each of the 5 core elements that are listed in the first columns: policy and strategy, system strengthening, capacity building, measurement and monitoring, and innovation and research. And for each key driver, 5 suggested implementation strategies are then presented in the main body of text of the white paper. And I wish to stress this: person-centered care is not just the ethically right way to approach and care for patients, it's also one of the foundational pillars for patient safety. So, one of the foundational pillars is patient safety, is patient, family, and carer engagement and empowerment. Why is that so? Well, it is because what we want to do is to empower and engage patients, families, and carers in patient safety efforts, and to ensure effective collaboration between healthcare providers and patients to improve safety and quality of care delivery, what we call co-production. That's the mode we should be thinking in. And we will now examine the key drivers within each of the 5 core elements for this foundational pillar and briefly discuss the implementation strategies that are suggested for each of the key drivers. So the first core element is policy and strategy, including health equity. And what can you do here? Well, the key driver, we believe, is that the facility should develop a patient and family engagement strategy and policy that involves the patient, family, caregiver voice and input in operations and quality and safety initiatives,
Ibu
while
Sandra,
ensuring health
yang
equity
dialami oleh Ibu
considerations
Good job, good job.
by considering diverse cultural, linguistic, and socioeconomic needs. And specifically, you should work with culture. Create an organizational culture of engaging patients. This should be the way we do, the way we believe that we should act.
kita ingin membagikan kebaikan Yumi yang sudah kita alami.
Good job.
Please, someone has a microphone on. Please mute them. The next one, the second, within the culture, you should consider different cultural, linguistic, and socioeconomic needs to ensure health equity. You should promote open communication, provide psychological support after serious patient safety events, and you should encourage active patient participation in their care decisions. Also, as part of the policy, you should consider establishing patient and family-centered advisory committees. You should involve patient and family members in care planning at the institutional level, not just involved in their own care, but also in the considerations you have at an institutional level and how you organize, how you prioritize your care delivery. Patients should have provisions for second opinion, and leadership should promote the WHO's Patient Safety Rights Charter. It's a charter that was developed within the framework of the World Patient Safety Day 2023, and it describes 10 patient safety rights, one of them the right to patient and family engagement, and you can find it on WHO's website.
Yes.
And now to the second pillar, which is system strengthening for risk reduction. And this would include including patient, family, and caregiver representations in governing boards, quality and safety committees, event learning teams, and patient grievance committees and teams. So you should actually actively involve patients and families in the design and evaluation of care pathways. You should encourage patients to become members of your board. You should support patients with knowledge and tools that they need to actively engage in safety practices such as infection prevention, medication management, and recognizing warning signs. In all of these areas, the patient voice and the patient cooperation can play an important role to improve safety. You should facilitate patients and families' active participation in risk mitigation and event learning. And to facilitate inclusion of everyone in these activities, you should develop multilingual educational materials, signage, and consent forms that are culturally sensitive. And you should provide interpreters when needed. Next driver is capacity building. Develop and engage patients, advocates, and activists and patient safety champions in the design and delivery of healthcare. You should integrate patient and family engagement into healthcare professionals' curriculum and ongoing training. Integrate patient and family experience into healthcare worker education. Use real-life stories, use feedback, use training and simulation sessions, but also create room to reflect on what happens during actual operations. Train healthcare professionals to disclose patient safety incidents to patients and families. Train staff to analyze and respond constructively to feedback from patients and families. And equip and empower patients and families with information related to the care journey using a variety of formats. It's not only building capacity within staff, it's also building capacity within your patients and their families and carers. Then measuring and monitoring is another key core element. You should adopt and monitor PROMs, patient-reported outcome measures, in addition to standardized patient experience measures for periodic review by leadership and boards. So you should create systems for patients and families to provide real-time feedback. It could be regular patient reported experience measures collected during surveys, but you could also do other things such as simple things as setting up suggestion boxes, or you could arrange for follow-up interviews. You should also create a structured PROM framework, a PROM framework that extends across many conditions, and there's a lot of knowledge in the literature that would inform you on building such frameworks and selecting the right indicators to monitor. And of course, you should not just collect the data, you should also establish a process to evaluate the effectiveness to analyze and review the data and use it to create recommendations. And you should establish a process to evaluate the effectiveness of patient and family involvement in committees, etc. And you should also, when you collect PROMs and PREMs, you should stratify the data to explore disparities related to social demographics to get the most out of the data you collect. And then finally, the core element innovation and research, where the key driver is innovate at adoption and spread of communications and resolution programs that address transparency and subsequent patient family needs following patient safety incidents. Establish a clear communication and resolution program outlining clear protocols for patient safety, incident communication and resolution with pre-designated roles for staff. Leverage technology to integrate documentation you create in this way into existing incident reporting system. Connect the dots, no silos of information, the analysis, the outcome of the analysis, and how it's communicated and used to improvement. All of these should be connected and integrated. Implement digital health tools, apps, or online platforms for patient empowerment, for chronic disease management, ensuring their availability in multiple languages and making them accessible to all patient demographics. Encourage and conduct research studies to test new patient engagement methods, learn from what you're doing and use the learning to improve. And finally, develop an internal and external knowledge sharing platform, knowledge sharing hub, you might call it, for patient engagement innovations, for best practices, case studies, and research findings, and maintain a digital library of resources for staff, patients, and families. Now, we created in this white paper a set of 100 strategies, and we do not expect that a hospital will decide to work along each of these 100 strategies as from tomorrow. Some selections and some prioritizing is needed. But on the other hand, there's no single magic bullet. The approach must be multi-pronged. And you will also have realized from the examples you have heard that many of the strategies as the white paper suggests to you are there related, they're synergistic, they're different aspects of a common approach. And you need to leverage, you need to work on multiple lines, and a number of the approaches you should take are illustrated on this slide. Use prudent standardization, leverage human factor science, the understanding of how humans and systems interact, leverage the power of teamwork, build a culture of safety, build a resilient systems. That's what I referred to when I was talking about a system that's able to monitor, anticipate, monitor, adapt, and learn, anticipate what might happen, which is not always clearly predictable, be able to monitor what's going on in order for you to be able to adapt to the needs of the actual situation you are in, and learn from your experience. Co-produce safety with patients and families. Improve using principles of change management and implementation science, and leverage technology, including AI. So all of this is presented in this white paper, and I will share my presentation with you. And here you can see a barcode that allows you to download it, and you can also use the link on this slide. And before I finish, I would just like to share this with you. We have our annual conference this year in Brazil, in Sao Paulo, in October. And at previous preferences, we have been very happy to see a great number of participants from Indonesia. We know Brazil is a little bit further away than some of the previous conferences have been, but we still hope to see a lot of you there. It's really a good opportunity to meet international colleagues and exchange experiences and learn from each other. And finally, on this slide, a number of ways in which you can reach and interact with ISQUE. And with that, thank you for watching this presentation, and we will move over then to Q&A, I believe.
Thank you very much, Dr. Carsten Engel. Somebody wants to have questions? Please write it on the chat, or while we're waiting for somebody to ask, what about if we ask Dr. Anuradha to show her face? She's the one who working hard for this white paper. Please,
Yeah.
Dr. Anuradha, can you please, Mr. Indra, pin Anuradha. Anuradha, are your video on? Hello, Anuradha.
But as we may have noticed, Dr. Anuradha from India was the lead author of the white paper, and she is a very, very engaged champion for both patient safety and person-centered care.
Can you,
Hi, Juni.
can you, yes?
Yeah.
Can you pin
Thank
Dr.
you.
Anuradha, please? Oh, here you are.
Yes. Yeah. Thank you. Thank you so much.
Yes.
Thanks
Can
for
you give
making
some
me
words?
join.
How hard you work for this?
Okay. Yeah. So it was a great teamwork with Dr. Carsten and the people with WHO and other experts. We had from 7 countries writing this paper together, and all of them are experts on patient safety. And that's how we were able to do it. And this is completely aligned to the Global Patient Safety Action Plan. And this is more focused on the healthcare organizations directly to improve the patient safety, as Dr. Carsten was telling us. Thank you so much.
Yes, thank you very much. For the first question is Dr. Sutoto, please have your time.
Thank you, Dr. Hani. Thank you so much, Dr. Carsten, for such an engaging and eye-opening presentation. The way you deliver made the complex topic feel relatable and easy to grasp. And your message resonates deeply with our effort in Indonesia, truly inspiring. Dr. Carson, may I ask, in your view, from a health policy and governance perspective, what systemic action and strategic policy shift should government and regulator undertake to ensure that patient-centered care is not only implemented at the clinical level, but also integrated into national safety policies, funding mechanism, and the daily operations of hospital? Are there examples of cross-country policies that have successfully mainstreamed PCC into public health system? Thank you, Dr. Carsten.
Well, I would say, sorry, I would say for a country that has a national accreditation system, this accreditation system is a very good way of making sure that person-centered care is on everyone's agenda. And actually, if an accreditation program is to be accredited by ISQA EA, then standards has to address person-centered care, and that will be further strengthened in the next version of the principles. So accreditation is a way to make sure that everyone is aware, everyone knows that they will be assessed against it, but they're also provided with some incentives in form in that they know they will be assessed against this. So that's one way of doing it.
Thank you.
And there is a question in the chat about metrics we could use to gauge how well we are implementing patient-centered care in our practice. And yeah, well, as patient-centered care is defined in a way by the experience of the patient, then one way to do it would clearly be to ask the patients, collecting patient-reported experience data. But as this is a co-production and is something that is created where patient and staff meet, I think it's also important to assess the attitude and the culture among staff, because that's also needed to create the culture of patient-centered care.
Any, Dr. Nicole?
Thank you, Dr. Ani. Dr. Carson, thank you for your very informative presentation on the white paper of ISQA. When we engage, empower the patients, then there is an element of culture. You have a Western culture, you have an Eastern culture. Could you comment on the element of for engaging or empowering the patients with these two elements, very different, what you call it, very different aspect. Thank you.
Sorry, what was what was the question?
Yeah, when we empower the patient,
yeah,
we engage to them. You have the doctors, nurses from Western people with a Western culture, very open, etc. But you have also Eastern people, Eastern doctor, nurses. Could you comment on this different culture engaging and empower the patients.
Well,
Thank you.
well, actually, I would believe that you understand your culture much better
Yes.
than I do,
Yeah.
and you will understand best what is needed. What is the essence of
Yeah.
person-centered care, in my view, is to bring the patient and the families to the table in the way that's appropriate to your culture, asking questions that are appropriate for your culture. And if, I mean, in the West, some professionals would be concerned about losing power, being forced to doing things that they do not want to do. But that's not what person-centered care is about, because it's about creating a situation where we all come together. Patients bring one kind of insight, priorities, values. Staff brings another, and it all operates within a certain system. We can't give patients everything they want, and that's not what patient-centered care is about. But when we decide and prioritize, the patient has an equal voice and an equal say in determining what's important. So what matters to you is, to me, a core emblem, if you like, on what person-centered care is.
Yeah. Thank you, Dr. Carson. The second one, very short. Maybe it's more acceptable to so the optimization of what matters to you will be done. What about questionnaire of prompts and prems? Using questionnaire of prompts and prems.
Yes, it's very important that those questionnaires are not just translated; they must be validated in the local context.
Yeah. Thank you very much.
Thank you very much, Dr. Nico. Thank you very much, Dr. Carsten. We have some questions from Gofe Salya. I think it's from India. What metrics can we use to gauge how well we are implementing patient-centered care in our practice?
That's done, honey. It's
Huh?
done. It's done.
Oh, it's already
It's already
answered.
already answered by Carson.
Oh yeah, okay. Okay, Carsten, one last question from me. Can you share the key findings from the white paper to your opinion? What's the most important thing?
Well,
everything
as
is
I
important.
say, no, but as I said to you, there's no one magic bullet. The important thing is, I think, that you need to have a considered, prioritized strategy, and that you execute the strategy, take it through, follow up, and use data to monitor your progress.
Yes, thank you very much, Carsten. All your friends from Indonesia is here.
I'm very glad to see all of you.
Safir Oas loves you, and I've met you in person in Korea.
Istanbul,
Yeah,
I think in Istanbul
in
last
Korea.
last
Yeah.
meeting.
Yeah.
Okay, thank you very much. Have
Thank you.
a great health, a great happiness. See you in Sao Paulo.
See you.
Okay, thank you. The next speaker will be Dr. Salma Yauni. Please put her curriculum vitae. Yes, my short comment, Salma Yauni is the queen of our board member from ISQA. Please have your time, Salma.
Thank you. Thank you, everyone. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Thank you for the organizers for inviting me to join this very important and prestigious online seminar. And I am very happy, and I have been asked to share what we have been doing here in Jordan in terms of patient-centered care, and how we have been pushing it up the agenda of decision makers and so on. So I will share my presentation now, and like Dr. Karsten, I will put it in the chat at the end of the presentation. Please let me know if it is not working, or if the slides are not moving. Is everything clear, Dr. Hani?
Yes, everything's clear. Fine. Thank you.
Excellent. So I'm going to start by talking a little bit about our journey at the Healthcare Accreditation Council, and then looking into patient-centered care and how we take things beyond accreditation. Jordan, for those who do not know it, and I hope one day you will be able to come and visit us, is a relatively small country. Despite the fact that our population today has grown to become 11 million, due to a lot of turbulence in the neighboring countries with a lot of refugees. So our population growth has not been very smooth or consistent, which, as you all know, would have a burden on both the health sector, education sector, and economy. And I wanted you to know how our health sector is divided before I start talking about it. We have three main providers: the public sector, where the government of Jordan owns and runs hospitals and primary healthcare centers. The military also provides a lot of tertiary care, and we have government-led teaching institutions. There's the private sector with around 67 hospitals and a multitude of clinics and diagnostic centers, and the nonprofit sector, where we have many UN organizations serving the refugees, a lot of NGO organizations, as well as a renowned cancer center that is run in Jordan. When we first started, and I'm going to take you back to 2003 probably, the main idea of developing standards and going forward with accreditation was really because we had problems at both the macro and micro level, like any other country at that time, and many of the countries that are now still struggling with that. At the macro level, the regulations were not clear or not being implemented. There was no data on patient safety per se. The policies and procedures were depending on where you work. There's no reporting culture or safety regulation. Even at the time, there was no medical liability law or requirements for continuing professional development and so on. At the micro level or the institutional level, we also had a lot of issues related to sterilization, maintenance, guidelines, continuity of care, privacy, medication, medical equipment, triaging, hazardous material, and so on and so forth. And as you can see, both at the macro and micro, this really impacts patients directly and their families as well. So Jordan decided to establish the Healthcare Accreditation Council to focus on continuous quality improvement and patient safety with the objectives of safe healthcare, quality services, a good supportive environment, and empowered providers. And I thank the person who asked about the differences in culture between maybe more developed worlds and a foreign culture versus cultures in Asia, in the Eastern Mediterranean region, and so on. And our components from the beginning were not only accreditation, but we wanted to work on all the different pillars that support patient-centered care, quality, and patient safety. So HCAC, the Healthcare Accreditation Council, works through two arms. One is the accreditor, and you have several accreditation bodies in Indonesia that work similarly to us, where we develop standards, we train surveyors, we provide accreditation, we do mock surveys, and so on. But different than many organizations around the world, we also have what I call the enabling arm. This arm is very important to focus on the relevant topics, on policy consultation, on preparedness of healthcare organizations, on training and quality management systems. So it's not only accreditation per se. We're very happy to announce that we are among the first 13 maybe organizations in the world that were able to achieve in 2007 all three ISQA accreditations and maintain them. We were the first in the Eastern Mediterranean region to have all of that. So let's start with the accreditation arm and see how that influenced really patient safety and patient-centeredness. To us, we believe that standards are a roadmap, are the criteria, are the parameters that really set what you want from a healthcare organization to do to ensure that it is providing patient-centered care. So at HCAC, we now have maybe more than 15 sets of healthcare accreditation standards, ranging from organizational, such as hospital, labs, primary healthcare, to more in-depth issues like breast imaging and medical transport, and also to things such as family planning, lactation, diabetes, and others. Why do we say standards form the basis of patient-centered care? We really believe that because also if you're following ISQA requirements, there are specific characteristics of standards. They are guidelines for quality of patient care. They're not prescriptive in nature, so they're not a checklist to tell you do this, do that, open this, close that. They are patient-centered and they are educational in aim. They want you to learn about the things and move you forward from there. So in patient-centeredness, it's one of the 4 core characteristics of standards, looking at dignity and respect. And this is where our values, our different values across the world, beliefs, cultural backgrounds come in. It believes in information sharing between providers, with the patients, among the decision makers, participation. So you are not talking to the patient, you're talking with the patient, with their families, and there's continuity of the service that you are providing. So this is how we develop our standards every time we write one of them. Of course, that is very parallel to international definition of what is patient-centeredness. You have patient rights, dignity, and autonomy as core. You have effective communication and informed consent that is required from the patient and their families. The family is involved. In some parts of the world, families don't get involved. It's the patient on their own. But in our part of the world, in our culture, it's not just the immediate family member. It's sometimes the whole tribe coming in, and you have to deal with that in a way to respect the culture, but as well as be cognizant of what the patient really wants. There is emotional support, and that's very, very important, as well as ensuring accessibility, safety, and comfortable care environments where the service is being provided. Our standards are divided into clusters. Some other organizations call them chapters, others call them modules, others, and so on. In HCAC, we call them clusters. For each principle of patient-centered care, we show you that there's a direct mapping to our clusters. So when we talk about respect for patient values and preference and needs, that you will find it definitely in the cluster on patient care, and that on ethics and patient rights. If you want to talk about physical comfort, you will find it in cluster 7, environmental health, safety and sustainability. If you want to talk about involvement of family and friends, you will find it in the ethics and patients' rights cluster. The continuity of care, you will find it in medical records, in the diagnostic services, in the access and continuity of care. In information and communication, you will find it in the information management, and so on and so forth. So we truly believe that the standards form the proper basis of patient-centered care. These are examples extracted from maybe our hospital standards. And it shows you how every standard has clear requirements, and there's an ability to map it to patient-centeredness. So when we talk about the hospital informs patient and families about its services and how to access those services. Hospital entrances are well marked, visible, and internal signage, etc. That is very clear on how it is related to patient-centeredness. It is also, for example, there is a defined process for providing patient and family education. There is a transition or a referral system that helps the patient continue and follow up on their care. That all falls into patient-centeredness. In Jordan, we have more than 300 organizations today applying these standards regularly through our very rigorous accreditation process. It's a 2-year process for hospitals, 3-year for others. It includes a midpoint assessment unannounced where we visit the institution to check on especially patient safety issues. And just looking at the number of those organizations, it tells you that every day somebody is looking at patient-centered standards and trying to apply them in those organizations, because they have to do it over and over again, and because the standards are changed every 4 years, improved, increased, adopted to the world requirements and to the Jordanian system. There are a lot of studies that support what I'm trying to tell you. And I just chose a couple of studies. I'm not going to go through all of them. They are available on our website. You can pick them at any time. If you look at this study that looked at 15 hospitals before and after accreditation, you will see the patient-centeredness standards or criteria, like ethics and patient rights. They had only 14% compliance to those standards. For patient assessment, they were at 2%. For patient care, they were at 15%. For access and continuity of care, they were at 14%. If you look at all of this together, it's around an average of 10%. So applying the accreditation roadmap and journey to those hospitals have improved patient-centeredness and patient-centered care up to 90% for those getting it from there. There's a study done by the World Bank earlier that showed practices by accredited organizations form opportunities for patients and staff to voice their concerns, to voice their ideas. There's a change in the quality of care, culture of quality. There's transparency. There's a culture of respect for patient-centered care. So this all shows you how we utilized in Jordan the standards as our way to enter patient-centeredness into every single organization that works with us. Another study also done by the World Bank showed that even the time spent by the provider with the patient in an accredited organization is much better than that in those non-accredited primary healthcare centers. And there are health committees that became very active at the community level so that they can support what the patient needs and what the families require. This is in the world of accreditation. However, we truly believe that there is a lot to do in parallel to accreditation. We design quality programs related to reproductive health, to social care, to breast imaging. We implement quality management systems through our enabling arm. We do cross-cutting topics on nutrition, baby-friendly initiatives, guidelines, and so on. But wherever we go, we realize that we always go back to a set of standards that starts the journey. We also believe very much in investing in the manpower, the people who are required to provide the service. So we run a multitude of workshops where in every slide, there's a comment about patient-centeredness. These workshops are about big topics such as infection control, occupational safety, emergency preparedness, but also about leadership and nursing and risk management and so on. We run a conference every other year, and we have one coming up this year in November. I hope you will be, some of you will be able to join us. We would love to have a delegation from Indonesia attend. And we also and it is the first ever in the Eastern Mediterranean region conference jointly with ISQA. So hopefully we'll see many of you in it. And we also developed a platform. It's 5 years old now. It's called eJawda. Jawda is quality in Arabic. And this platform is really where we provide all our training, free courses, information, so that people have continuous access to information on patient-centered care. We run every year during the Patient Safety Day, which is usually, I think, on the 17th or 19th of September, as designated by WHO. On this day, we ask people to pledge to do something that is related to the patient. So last year, it was about the patient's voice. And more than 50,000 people participated in this event, each one in his or her own organization, and then they post around what they have been doing, which keeps patient-centeredness at the heart of our day-to-day life. We've also introduced models like the family health teams, where patient-centered care is provided through multidisciplinary family health teams. We looked at gaps in governance, infrastructure, and workforce. We emphasized community engagement. It allowed for improving access, quality, efficiency, and equity. It served better the vulnerable populations. It also adapted to the changing health needs of the population, as I mentioned, with a lot of refugees coming into Jordan. And it also modernized and strengthened primary health care in Jordan. We also implement several projects through different types of funding with UN organizations, formerly USAID, and others that focus on the patient and patient-centeredness. We developed the Patient Experience Program, which we run it across primary healthcare centers. We also have a program on the patient voice, and this includes providers, staff, and administration. And we run the measurement of patient experience and patient-centered care in reproductive, maternal, and child health services competence across the sectors. Last but not least, all the work we do with organizations, all the work we do at the people level, all the work we do at the patient level has to come together into a plan for Jordan, HCAC played a key role to influence policy and decision-making, and most recently, we participated in the design, development, and launching of the National Quality and Patient Safety Strategy for Jordan, which stems up to 2030. We made sure that it focuses on and supports patient-centered care through focus on equity and access, the ability to respond to the needs of people, talking about patient satisfaction, ensuring integrated rather than fragmented systems, and providing workforce training and governance is a key component of our strategy, of this national strategy. So with that, I would have given you an overall view of what we do at HCAC for Jordan and how Jordan has responded to patient-centered care. And I will leave it now for questions and answers and comments. Thank you so much.
Thank you, Salma. The first question is from our head executive, Dr. Sutoto, please.
Thank you, Dr. Hani. Dr. Salma, thank you for your insightful and inspiring presentation on Jordan journey toward patient-centered care. Your country progress is truly remarkable and offer valuable lesson for many of us. May I ask the following question? What have been the most significant challenges in shifting from a provider-centered model to a truly patient-centered healthcare system in Jordan? And how were those challenges addressed effectively? And the second one, could you kindly elaborate on how Jordan national policies and accreditation standards have played a concrete role in supporting the implementation of patient-centered care at the hospital level? Thank you, Dr. Salma.
Thank you, Dr. Sutoto. They're very complex questions, honestly, to answer. Of course, through the presentation, it shows that it has been purely mastered in Jordan, but that is not the case. We still have a lot of challenges. We have a lot of changing ministers, and their priorities change every time they come into action, and so on and so forth. Let me start with the second question. Really, the accreditation process is a voluntary process in Jordan. It's not mandatory. And hospitals that have joined from the private sector did not want to lose their accreditation at any point in time because it negatively reflects on them and their ability to perform. Especially that HCAC makes a big deal out of how important accreditation is for patient-centeredness. So we try to put that message out for the common people so that they understand that if an organization is accredited, it is better situated to care for them. For the government sector, they made a comparison between, especially during COVID times, they made a study between their accredited and non-accredited organizations and realized that those who were accredited were much better situated to respond to the needs of or the requirements of Corona. And therefore, from that study, they realized that they would like to enroll all of their primary healthcare centers and hospitals to maintain accreditation, and has become a national sort of drive. Patient-centeredness comes really in round 2, if you want me to answer the first question. The first round of accreditation is really spring cleaning. It's getting your business in order, getting your policies, procedures, systems in a hospital or in a primary healthcare center to be compliant to world requirements. It's trying to make people understand how to do it and respond to it. In the second round of accreditation, this is where we have found that the people who are working in the hospital or primary healthcare center have developed a culture of thinking of the patient. And in the third and fourth round, this grows much better, and you will see that their indicators and their all their systems are very, very patient-centered. They really speak the language, they implement it, and so on. So it's, in a nutshell, in an answer to both questions, doing it over time, focusing on standards, putting yourself out there so the people understand what you are doing, are critical to patient-centeredness and compliance to patient-centered standards.
Okay.
I think there are questions in the chat,
Yes.
but I haven't.
I read it. I read it for you. There are 3 questions. One is from. Wait a minute. It's
Thank you, Dr. Salma.
okay. This is one from Liz Pramana Sari. Assalamualaikum. Thanks for the opportunity. My name is Liz Pramana. I'm from South Sumatra, Indonesia. I would like to ask Mrs. Salma Juni, what do you think and comment about patient safety in medical tourism, considering its health risk association with travel itself and lack of proper follow-up care?
Unfortunately, medical tourism has become a very hot topic, like brands of clothes that you want to buy and so on. And there is a big, huge misuse of promoting medical tourism in the real understanding of medical tourism. Medical tourism should be for patients who are unable to get the service in their home countries and go to safe, well-accredited, well-served countries and healthcare institutions that are able to give them the full process. It's not a shopping spree. It is really a need that is provided. So I think there are a lot of gray areas in the medical tourism. There are organizations that tell you, we give you an accreditation for medical tourism, and it's really about a few medical records and so on. There is no international proper regulation for medical tourism per se. And I think it is our role as accreditation bodies, maybe ISQA and ASQA and others, it's about time to come up with the minimum requirements for accepting medical tourism into any country. Medical tourism is not just about going to the hospital and choosing the doctor. It's about verifying the qualifications of the doctors that are doing the procedure for you. It's about, in Jordan, for example, 3/4 of medical tourism is not inside the hospital. It is in clinics and in laboratories and in dental clinics. It's not inside the hospital. So it's very hard to control that environment. There should be very clear reporting systems online where you show the healthcare outcomes. So I really don't have a specific answer, but I think absolutely this is a topic that is not centered on the patient. It is centered on the business. And we have to move it from being centered on the business to being centered on the patient. And we have to all work together towards that goal.
Yes, thank you. There's another question from Amelia, University of Hasanuddin, Makassar, from South Sulawesi. are there any sanctions imposed on hospital with high incidence of adverse events? What policies and regulation are in place to address this issue?
Thank you for the question. Jordan has always had a very strong healthcare system. And our reports show very good healthcare outcomes and not drastic incidence reports. Our population was small. Our system was very strong. As it grew, of course, we saw a surge in incidence rates. Incidences cannot be entirely 100% towards sanction of a hospital. There are different types of incidents. And what is important is to learn from those incidences and not for them to happen again. So each hospital is required to have a policy and procedure on how to deal with those incidences and compare it to the regulation system. So we have a medical liability law or we call it a medical responsibility law in Jordan, along with the syndicate of doctors and the Ministry of Health who monitor all of those incidents. So it depends on how drastic it is. For incidences where there has been a huge impact on the patient in terms of quality of life or, God forbid, death, these are automatically reported to the Ministry of Health, and there is a committee, a high-level committee that investigates what has happened, and then based on the outcomes of investigation and based on the regulatory system, there are, of course, sanctions and or any other type of punishment that takes place. They cannot hide. Jordan is a very small country, so if someone sneezes in a governorate that is 2 hours away from Amman, everybody in Amman will know. You can drive from the north of Jordan to the south of Jordan in a total of 6 hours. So it is very hard to hide those big incidents and not to know what kind of action has been taken on it.
Yes. Salma from Carsten Engel. Salma,
Yeah.
you were nicely illustrated this point in my answer to the questions on how national policy can promote patient-centered care. Thank you. Now there's 2 more questions from Jill Ayu Dewanti. Dr. Salma, regarding beyond accreditation, then how to make sure that PCC implementation constantly maintained among healthcare facilities in your country? Thank you.
Thank you. Whether it is PCC or any other standard, we all know, and the research shows that after the accreditation survey, there is always sort of a dip in compliance. But the research has also showed that the continuous requirement for re-accreditation makes this dip smaller every time. And then you go higher than your achievement and a bit slow and higher. So there's a consistent growth in compliance to standards, especially those that are related to patient-centeredness. Now, what do we do in the 2-year or 3-year period between accreditation and re-accreditation? As I mentioned, we do at the midpoint, we do an unannounced visit to the healthcare institution. We look really at the most critical standards, the patient safety related standards, employee safety. These are very, very important. We look at them, we look at the data, we do the site visit and so on. We also monitor the media. Because we are part of this country, we monitor the media very closely. We have a complaints record for anyone to complain or compliment or anything. And we continuously engage through our enabling arm not through our accreditation arm, with the accredited organizations to make sure that they are regularly picking up different types of programs that continuously support compliance to patient-centered standards. So very quick example, an accredited organization can work on the lactation counselor, the lactation, the baby-friendly, the mother-friendly, the youth-friendly programs that we have. Through those programs, there's always a comment and an assessment of patient-centered requirements. So we try to keep this balance between being an external evaluator and an institution that supports programs in different activities related to patient-centeredness. Thank you.
Very good. Maybe the last one is from Dr. Nico, please. But there are some questions maybe you can answer afterward.
Thank you.
Yeah, I will look at the chat once I'm done talking, and I will answer anything that we have not answered yet.
Okay, thank you.
Thank you, Dr. Rani. Dr. Salma, thank you for your excellent presentation. I just wonder, in Jordan, I have data that about 20% hold GCI accreditation. And your standard, PCC standard, and GCI accreditation, we know there's a PCC chapters in the standard. How do you handle this duplication? Let's say it's duplication. Thank you.
First of all, no, not 20%. There are maybe 5 hospitals in Jordan that have the Joint Commission accreditation. We have a total of 129 hospitals between public, private, and so on.
Yeah.
But again, we do not mind JCI or Accreditation Canada or the Australians or the Indians or anyone to come to Jordan and offer their service. At the end of the day, it's an open market.
Yeah.
And it is not about us worrying about how they comply to the patient-centered requirements, because being accredited by ISQA, all of us have almost the same chapters and the same requirements. Very, very little differences in our standards. So I asked once the director of the King Hussein Cancer Center, which is a very important regional cancer care center, very renowned. His organization has the Joint Commission, it has HCAC, it has ISO, it has CAP, it has HACCP, it has Magnet, it has... So every kind of accreditation you can think of, they have it. So I asked him, how do you deal with that? How do your employees deal with all of those accreditation? 2 answers. One, the quality team and the quality coordinators in the hospital and the champions for quality have developed a quality management system, not for accreditation, but for being a quality organization. And then applying for CAP or Magnet makes it very easy to have it. Why do they apply for all of that is his second answer. It is a way for the administration to make sure that the whole organization is continuously in compliance with the requirements of standards for patient-centeredness. So it is about them, not us, really, to worry about it.
Okay, thank you.
Thank you.
Okay, thank you very much, Salma.
Thank you. I'll try. Thank you so much for having me. I'll try to answer the questions online, and I will post my presentation as well online now when I get the things in order.
When I remember you, I remember Petra.
Yes, and I invite you all to come to our lovely country in November for our conference, and we'll arrange for you all the trips to Petra, Jarash, and the Dead Sea.
Yeah, our president is has been staying for some time in Jordan.
Yes.
Yes, is a friend of your king.
In the past
Okay,
time.
thank you very much. Next will be our last speaker, our beloved Professor Tonang.
Thank you.
Please, is curriculum vitae.
Nggak ada Pak, dan Mbak
Oh,
Hani
no,
langsung.
no, no. Okay. Yeah, please. Everybody knows Dr. Tonang because he's the most important person in Indonesia. Please, Dr. Tonang, have your time.
Thank you, Dr. Hani Rono. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Let me share the presentation. Has it been okay,
Yes,
sir?
okay, very
Okay,
good.
thank you. Well, this is a very honor for me to present this among the Dr. Carstens and Dr. Salma, very distinguished speaker, and for me, it's just a learner on this field. So please apologize for any inconvenience, and please revise or any mistake I made on these presentations. My duty should be present PCC implementation in Indonesia, and considering two previous speakers, there are many things that come up to me as very interesting. So I hope that my presentation will complete as one of addition to those two distinguished speakers. This is just a definition that I'm sure that you all know about this. Very important is actually the next, the thing. This is one thing. I try to read, and there are sometimes it's actually the in the literature we have the person in person-centered care interchangeably with the patient, client, and so on. And in some time, it makes some people being confused on this. But I think this is another field and another discussion. But at least I come up with this issue. Next, this slide, Nico, and the milestones of the patient-centered care from the very beginning in 1996 of the 8 Bigger Principles of Patient-Centered Care. What actually come up to me is actually those time is also when we start the accreditation program for hospital in Indonesia, conducted by Ministry of Health in this time, and some of the godfather here is also the initiator of this accreditation program for hospital in those time in 1995 actually. What I should point is actually there are very significant role of the cars or Indonesians, ICAHO, Indonesians for hospital accreditations. This actually first come up in the 2007 when there is a PCC in the WHO workshops, Patients for Patient Safety in Jakarta. And I'm sure Dr. Nico is one of the chairman on this workshop. Starting from that, we have a very a very significant point to start to implement the PCC standard embedded into the hospital education accreditation standard. This is actually going on, and finally, lastly, there we have white papers from the ISQA, and Dr. Nico and friends has initiated to construct the PCC in Indonesia's model. This is very interesting. Okay. Let me first try to recall in those year 2006 during my PhD course in Japan, I was in time to present one of the paper that actually little bit different from my core of study. That actually I'm a pathologist in those time, but I rise with the questions about the dealing with doctor patients internet online relationships. In those perspective, I share about the changing paradigm that a patient become a very intelligent, patient become very informed persons, and it will really significantly support and initiate the very big change in the healthcare. What we have to know is actually we were in the era of Dr. Knows Best. That's the 20th century. But going to the next century, there are some several milestones we have to understand that we cannot be in the previous era to feel, to think, and to have a belief that we knows everything. No. The era today, as the patients become a very, very informed person, and we have to stand and to recommend to the patients. That's what I presented those time in 2006 in Japan. At the same times, in Indonesia, the first national guideline for hospital patient safety. This book was officially released on the July on 2006. And the year later, as I told previously, there are WHO workshop on the patients for patient safety in Jakarta. Then finally, it released a Jakarta declarations on patient safety. There are some points should be in Indonesian, but I try to translate it to English. But what the important point, I think that it is a very significant time point to initiate and start the implementations of patient safety in Indonesia. It is not that I want to say that the previous era we do not have yet this patient safety concept. It's not about that, and it's not like that. But actually, what I want to say is this is the official step to explicitly and to officially initiate the patient safety in Indonesian healthcare practices. What I can assure on this is actually we start the hospital accreditations on 1995. Gradually, it is completing the standard, and finally, we embedded the patient safety on 2008 in sequence with the release of the official guideline in 2006, and then the workshop of patient safety on the patient safety standard of Indonesia in 2008 in this time. What I want to assure you all that actually, even before this 2008, I believe that actually patient safety was implicitly being sold of standard, even it's not explicitly stated. Just on this 2008 that we explicitly stated about the patient safety concept on the Indonesian accreditation standard of hospital. And it becoming more vigorously maintained on 2012 standard, where we started to adopt, modify the standard of accreditations for hospital from GCI. And it's just Dr. Salma also explained about this. And we also believe actually that this starting on this, that the PCCS also strongly endorse, even with the gradual progress. This is actually the a little bit memory of us that about 30 years ago, 2012, when CAR started to release the official standard for hospital of Indonesian hospital accreditations. And yet, yes, we are sure that it's contained and cover also the patient center concept. What interesting in the previous chat of this webinar is questions about how this PCC has been included in the Indonesian's medical curricula. Actually, starting on 2006, in coincidence also with the release of the official guideline of patient safety, we also initiate to include this patient safety into the medical curriculum. There are 7 competencies as main pillars for this medical competency. Among those are effective communications, and then patient management, and ethic professionalism. As we hear previously from Dr. Karsten, says actually PCC is not about right in the ethic aspect, but it's also a main pillar for patient safety. And considering these 7 competencies in medical curriculum on 2006, it is actually patient-centered care's values have already been included in the 7th pillar of medical curricula. And when we revised this curricula on 2012 and then 2019 and recently on 2022, it is really that patient-centered care as part of the patient safety has more and more significance that Dr. Carstens also recommend to include the PCC on the curricula. It is actually, yes, we have included in the curricula. One of the proof is that we try to construct a prompt sentence in questions or the tutorial sessions for the medical students that we endorse using the model of questions to stimulate the students to think beyond the patient health problem. But not only that, we also endorse the comprehensive and continuous care toward the patients as an individual, as also a family member, and even as a member of society. That's what the curricula started on 2006, trying to stimulate our medical students. But even yes, we understand that the patient-centered care concept has been the curriculum. Even yet, it is challenging that sometimes we know that the written curricula is not yet the practical curricula in sometimes in practical days. And this is our challenging even until today. I will show you in the next how this perception is actually the case. Let's just say about this prompt. Instead of using the first model of prompt in the tutorial sessions, we endorse to use the second model that once again to stimulate the student to think beyond the problem, the health problem, but to try to perceive a patient as an individual, as a family member and a member of society, not only in the frame of a health problem. I think that's also a point to broader our perceptions about patient-centered care, and sometimes people use the word of person-centered care. Okay, this is a report on 2013 from the nurse journal. It is discussed about the person-centered care in the Indonesian healthcare system from the point of view of nurse, of course. There are three comments emerged from any discussion and review on this patient-centered care in the journals. First is the participation and involvement of patient and relative. Second is respect for patient value, preference, and needs. The third is information and education and sharing knowledge. That's the three main emerging in common for any discussion about the PCC. We agree that PCC is essential dimensions for healthcare. But however, in how PCC is implemented, it differs between countries in response to local characters, resources, and customer expectations. I think Dr. Carstens also previously stated on this. This paper provides us about three barriers in implementing the PCC in Indonesia. First is a decentralization policy of government. This policy point out the disparity of the authority between the government, national government, and the local government, such as the federal government in America and the state this policy, and this become a barrier for implementations of PCC. Second is about workforce issue. I think this is a common issue that come up of any discussion about PCC. The third is health education and social certification. And please remember, and please let me remind that in this report, it is in the pre-Indonesian's national health insurance era. So it's also another point of issue. There are also three barriers that specifically contribute for the nurse having difficulties in playing role of PCC implementation in Indonesia. First is a lack of clinical authority. Yes, we understand that in those era, there are still some, how to say, a gap between the nurse and the medical doctors. We hadn't yet in this time understand the shift paradigm about medical doctor as a captain of the shift into the manager. This is some very big question in those time in 2012 and 2013. The second is a lack of in communication between nurse and patients. Is it really sad? But yes, we have to admit this is the case that in this time there are several moments that nurse has a lack of in communication with the patient effectively during the shift. This is some sad moment, but I think we have to admit it as a part of initiation for improvement. The third is lack of communication between nurse and doctor. Again, there are some segregations that, how to say, that's the real. Even we do not like that, but yet that's the reality. What interesting is there are three enablers also for PCC implementation in Indonesia. First is decentralization itself has becoming how to say stimulant that for some states government, let's just say local government, become some local government very active, very positive in view for PCC implementations, while another is in opposite. So it's becoming a benchmarking conditions in this. So this is also an enabler for implementation of PCC. The second is 2013, starting we initiate the constructions of the Act for Nurse. So it is a time for nurse becoming recognized as a professional, as a partner of a doctor. That's a very good point in this moment. Also, having the nurse as recognized as a professional, there is also a very big spirit to initiate the nurse competent development to becoming affordable and becoming how to say a partner, a good partner and a competing partner and completing partner for the medical doctor. That's the report of 2013. On 2000, and then after that, we start the Indonesian National the healthcare insurance in 2014. 5 years after that, when we say that Indonesian health insurance would become a barrier for PCC implementations, I think this is a big issue on this, but it's not for today's topic. But 2019, there are two reports interesting. For patients stated that the healthy quality of hypertensive patient is determined primarily by the attitude of the doctor and the patient and doctor interaction and the communication developed between doctors and patients. Really, this is a very, very PCC sense on this report in 2019 in Indonesia. This is for primary care. In hospital, also in 2019, there is the most west part of Indonesia and a very unique and specific Islamic culture in those areas. PCC in Banda Aceh is largely been implemented in those times, but there is still a need improvement, coordination and communication skill between healthcare providers in the preparations of discharge planning. This is the report of 2019 to improve the continuity of healthcare, one of the standard of the hospital government. So yes, PCC has been largely implemented in healthcare, even under scheme of health insurance. Yeah, health insurance is not a barrier. Finally, yeah, to some point yes, but largely it's not a barrier. Nevertheless, some room of improvement are present. There are very dynamic reports on the Indonesian implementation of PCC. This is 2013, 2024, 25 even. There are some recent reports on this. But yes, I know. In those reports, we might say that there are some achievement as well as also barriers were noted. But at least this dynamic report on the PCC show us a significant indication, a significant signal that yes, PCC has been implemented in Indonesia. And those behind the skin of having very dynamic report on this PCC. Quality study in 2020 reported about barrier enablers to implementations of person-centered care in Indonesian hospital. There are three barriers that emerge from this report. Time constraint on and work. I don't know, but these three things become again and again as a barriers in the PCC implementations. But in another side also, three enablers will also emerge, including leadership, also what Dr. Carsten stated on the chat in answering some questions. So the qualitative study recommendations in the conclusions part that hospital managers and policymakers to overcome existing barriers using adaptive planning and strategies, and to improve enablers with well-trained professional and strong leadership. One of the questions the chat said, how we make sure when we enter strongly commitment to make it better and better. I think this is one of the report on 2024 pointed out very strong. Another is also a report on the 2024 is a culturally sensitive patient-centered healthcare, a focus on a health behavior modification in low and middle income nation. This is insight from Indonesia. We all agree that a general principle of PCC still need to be tailored with the local context, considering local culture, tradition, history, resources, and of course, current practices. Just as Dr. Carsten said that we know better about our culture than other people. So it means that we have to adapt this PCC in our culture. That's, I think, the most important message tonight. So in LMIC, including Indonesia, achieving the patient empowerment demands implementing a critical strategies that might be different from experience in other countries. Let's just say there are 30 hadris around that in Jordan to implement this PCC. In Indonesia, we have 3,000 hospital, almost 10,000 puskesmas, a clinic, how to say, primary care, and maybe also around that number of clinic. So very, very big in Indonesia. So just as Dr. Nico in several moments stated about the 7 dimensions of Indonesian's model of PCC, this is 7 that what I think and what I understand is being tailored from the PCC concept and standard internationally to become the Indonesian's local implementation of PCC testing. What interesting also in this report that, for example, the cultural concept of gotong royong, that is emphasizing communal collaborations, sets an opportunity to foster community to support the network between patients, not just patient-centered care, focusing on the functional of the patient, but it's also or even also community-oriented care that focusing on the quality of life of the patients beyond just the health problem. So posyandu or a puskesmas, widespread throughout Indonesia, that also need to be side of the PCC implementations, not just the hospital. So in the next slide, I want to show this is the implementing high quality primary care from the WHO, WHO, and it is pointing out about the person-centered, family-centered, and community-oriented primary care. And one of the example is the presentations of the implementation of more integrated person-centered primary healthcare services in puskesmas, in primary care, in clinic and in society, to have a better overall health outcome and well-being for people living with HIV in Jakarta and beyond. Ladies and gentlemen, from this webinar, I think this is what the WHO recommended on 2015, yeah, about the conceptual framework for integrated people-centered healthcare, and what we just tried to discuss, and I want to show you is how this implemented in Indonesia. What I might say is PCC Indonesia has been largely implemented and dynamically reported for achievement and barriers, also becoming the subject to discuss and progress in healthcare services of hospital as well as in primary care. We're sure that it is on the right track, even it's still in the early stage of development. That we should keep it getting better implementation as the opportunity of progress rise in simultaneously also with challenges. Thank you, and I'm leaving for the question and answer that I hope I might also consider to provide answer. Thank you.
Thank you very much, Prof. Tonang.
Dr. Hani, please.
There is no questions yet. Maybe it's
Yeah.
very, very late. Please, can you post your presentation here in the chat? So
Okay. Yeah. Thank you. I will share.
people can get it easily.
Thank you.
Dr. Nicolomenta will ask.
Sir.
Maybe it's
Yeah, sure.
allowed.
Question.
Thank you.
Prof. Tonang, do
Thank
you
you, sir.
have not data, but what you feel about the doctors in Indonesian hospital implementing PCC? Is it very big groups or what? Thank you.
Yeah. Thank you, Dr. Nico. Just actually the presenter said, actually we have included this PCC in this medical curricula starting on 2006. But we have to admit, even on the dynamic report of PCC, almost of all of the report are from the nurse, not from the doctors. I have to admit that yes, we still have a big, how to say, big burden on this, or if I may say, it's not a burden, it's a responsibility to raise the awareness of the doctors about this PCC. As we all know, even in the intercollaborations, interprofessional collaborations, doctors becoming a manager, but at least we also understand a very significant, but a small thing, small movement, small shift paradigm of a doctor will impact very big on the implementation of PCC. As also we know of the implementation of hospital accreditations. Without doctor participations, we know it's a very slow progress we might achieve for the hospital accreditations. But once doctors become champions and being proactively support the accreditations standard implementation in hospital, then the big significant progress we might get. I think this is also the case in this PCC implementation, Dr. Nico.
Thank you. Last question.
Yeah.
In the medical tourism, do you think this element, the doctors implementing PCC, is very important?
What I might say that actually in this medical tourism, just as Dr. Salma stated, maybe just 1/3 of the medical tourism would be in hospital in the case. More than two-thirds has been in the outside of hospital.
Okay.
And in this case, it means that we know outside the hospital, doctors still very dominant and very significant part of the healthcare. In hospital, we have many professionals working together, but the outside of the hospital, doctor becoming very significant. So I think without awareness of this PCC from the doctors, mainly doctors in the outside of hospital, it is a very threatening, how to say, threatening moment that we might embrace this medical tourism very enthusiastically lately. We have to be sure that even outside of hospital, PCC implementation is been something that we all agree to be very important. So in my slide, in my presentations, I also saw how this PCC implementation beyond the hospital in the primary healthcare and the community to raise our awareness that PCC is not only in the hospital, but beyond the hospital. Thank you, Dr. Nico.
Yeah, there is one question from Salma.
Yeah.
I have a question. Do you have a clinical governance system in Indonesia and monitored by PCC Institute? Not yet, yeah, maybe.
Yeah.
I'm afraid that we are not yet implemented officially, but I think CARS with the PCCI is a very good initiative in holding and maintaining the campaigns for the patient specific feature for the hospital and the healthcare. without any initiative from these cars, I think we have to be afraid that we are not yet ready and aware of for this PCC. So I think we have to thank for cars on this.
Yeah. And one more from Jill. Prof. Tonang, regarding
Yeah.
PCC and the diversity in tribes and culture in
Yes.
Indonesia.
Uh,
Then how the standards and accreditation for meet the requirements of specific and unique of it.
Yes. Let me quote what Dr. Karsten stated previously, that the people in those local area knows better about the culture, about the preference, about the needs, about the unique specific characteristic. So I think the people in the local area is the most important and most, how to say, notable persons how to implement the standard, the national standard, the hospital standard of accreditations to be implemented in the local area. What I think might be better is we have to maintain strong relationship between the holder of the national standard, such as CARS in this case, and the local, how to say, local government, local public figure, and of course, local healthcare professional. How to translate this national standard into local friendly standard. I think that's most important. And we also know that the one of standard of the hospital say that we have to adapt, we have to accommodate what the preference of patients in the language when we educate, when we communicate, and when we discuss the management in the hospital of a case to the patients. This is where a part of the Indonesian hospital accreditation. I think it means that every hospital should consider what they might provide the specific local language, specific local culture, or specific local preference when implementing the national standard of accreditation, patient safety, and specifically for the PCC. There is no smart and short answer on this, Dr. Jili Ayudewanti. But again, I quote what Dr. Karsten said, that you know much better than me about your local character, local culture, and local preference. Thank you.
Thank you very much. Thank you very much for the last speaker, the three super speakers. Maybe it's time, it's very late in Papua, maybe. Then I ask Dr. Nico to close the sessions, please.
Thank you, Dr. Ani. Allow me to close this excellent webinar. Good evening, distinguished speakers, Dr. Karsten Engel, Dr. Salma Juni, Professor Dr. Tonang, and CARS Executive Chairman Dr. Stoto, esteemed webinar participants. First, let us express our gratitude to the Almighty God for His blessings and grace, allowing us to successfully conclude this second International PCC webinar with inspiration and fruitful discussions. Honorable guests, colleagues, and distinguished attendees, today we have collectively explored the significance of PCC through profound perspectives from Dr. Karsten's presentation on the latest ISQA white paper. We learned that PCC is not merely a concept with a systemic transformation requiring collaboration among all stakeholders. Then Dr. Salma Juni shared invaluable experience implementing PCC in Jordan, demonstrating how this approach can be adapted across diverse cultural contexts. Equally compelling, Professor Dr. Tonang enriched our discussion with PCC practices in Indonesia, reminding us of the unique challenge and opportunities in our homeland. Dear participants, PCC is about refocusing healthcare services on patients as active partners. As we discussed, this involves two things. One, empathic listening, asking what matters to you rather than what's the matter with you. And the second one is service integration, ensuring coordination across professions and sectors. And the third one, patient empowerment through education and participation in decision making. To conclude, allow me to highlight three key takeaways for action. First, shared commitment. Let us make PCC a culture, not just a program. Every healthcare worker, from clinicians to management, plays a pivotal role. The second one, collaboration. PCC requires synergy among hospitals, governments, academia, and communities. Today's discussion must serve as springboard for tangible action. The third one, continuous innovation. Leverage technology and research of measure PCC's impact, such as digital tools or feedback loops highlighted in the ISQA white paper. Lastly, I would like to convey the motto of CARS for professional healthcare and patient care and implementation of PCC. That is in Indonesia, BPIS. Bila pasien itu saya. In English will be IPIM. If the patient is me, IPIM. Distinguished attendees, thank you to PCC CARS, ASQA, all speakers, moderator Dr. Hani Rono Sulistyo, and the organizing committee for making this event possible. My highest appreciation also goes to all participants for your active engagement. May the knowledge shared today not end here, but fuel our efforts toward more human healthcare services. And before we adjourn, let us close with the prayer led by Dr. Juni Dharmajaya. Good evening and see you at the next PCC webinar. Thank you and warm regards. Thank you.
Thank you. Thank you, Dr. Nico, because it's very late especially in East, so we skip the prayers. Thank you for everybody. See you on the third international webinar from PCCI, CARS, and ASQA. Good night. Thank you, Dr. Salma. Thank you, Dr. Karsten. Thank you, Dr. Tonang. Thank you, Dr. Nico. Good night. Sudah do you download already Dr. Karsten, Dr. Salma, and Prof. Tonang in chat? If you have connect, then maybe for the last time, can you share the photo of the Dr. Salma, Dr. Tonang, and is Salma still here? Yeah. Okay, thank you very much. We close this session. It's very late.
Okay, bye-bye.
The delay. Thank you. Good night.
You.
Terima
See you.
kasih, Prof. Thank you of the
Yeah,
speakers.
thank you.
Thank you, all speakers.
Thank you, speakers.